Good evening, everybody. Welcome to the 2022 Virtual Symposium. I hope that next year we have a better chance of being in person, but we'll see. So we'll keep our fingers crossed. But we have a pretty packed agenda, so I'm going to just jump right on into it here with my initial sort of 5 or 10 minutes worth of slides. I wanted to update everybody a little bit on sort of where we are in terms of the heart transplant program, and then talk a little bit about some of the innovative things that we're doing in clinic that you may be seeing and that we may be talking to you about. And then lastly, kind of finish up with a little bit of on a hopeful note as we kind of change our digital platform a little bit and see if there's ways we can kind of further empower the patients and the PFAC as well. Next slide. So we've been very busy, as you might have noticed from clinic. If you look over the course of the past 20 years, about 10 years ago, we were averaging somewhere around 40 to maybe 50 transplants a year. But about 5 years ago, the volumes really ticked up, as you can see, with the sort of solid orange bars. And the last 2 years, each year we set a new record for the number of heart transplants done at Stanford. 86 in 2020. And 92 in calendar year 2021. And it's actually even higher than that because when you include the heart and lung transplants, which aren't in this particular volume for administrative reasons more than anything else, we're actually over 100. So we've been really, really busy on if we go back to that slide just 1 second, I apologize. You also notice that our VAD volume, the MCS, the mechanical circulatory support volume, has gone down. And most of that reduction is because we're transplanting patients so quickly. So many patients don't need to have both a VAD and then a transplant. We're able to get most people there with just one surgery. That being said, I think there's still a very large unmet need for the destination therapy patients. So these are the patients who are sick enough for a transplant but aren't candidates for transplant and get the pump as sort of their permanent therapy. So hopefully we'll see that volume growing over the course of the next couple of years. Next slide. So what else about the program? So we transplant very quickly. We always have, but even more so over the course of the past couple of years. The graph you see there on your left in the sort of dark purple is the observed rate of our transplants. And the sort of lighter purple is what the national organizations sort of expect for Stanford. So you can see we're way, way over that. And when you look at that ratio, that transplant ratio, we actually have the highest in the entire country. The other place we're really excelling is the organ offer acceptance. So how often we accept an organ versus what is expected nationally. And we're the best in California and the second best in the entire US. With that, the waitlist mortality, meaning patients who are listed for transplant and the deaths on our transplant list are very, very low. Some of it's because some of the way we've managed our patients waiting for transplant, but a lot of it because we can get patients transplanted very quickly. Again, what we see in the observed in the dark purple is us, and what is expected from the national organizations are in the lighter purple, so we're much below that, and we're hopefully keep this going in the future as well. Next slide. And then lastly, kind of finishing on outcomes, our outcomes have been excellent and have been improving pretty steadily over the course of the past several years. The bottom of the chart, you can see sort of various time points in January and June or July, and this is when the national organization releases our information. So twice a year we get information about sort of how our program is doing. And it's a little bit busy, but you can see the blue line is our 1-year survival after transplant. The green line is what the US national average is, so across all transplants in the US. And then the red is what is expected from us. So you can see not only are we above what's expected, but we're also above the United States. And our last report from the SRTR, which is the organization that sort of holds all this data and publishes this data, we were at about 95% survival at 1 year, which is above around 90 or 91%, which is kind of across the country. So we're very proud of that. And not only are we above it, we're statistically significantly above it. And the SRTR and the organizations actually reached out to us to ask what we were doing that made our program so successful. So we're very proud of these results. And these results are not just me, it's not just the physicians, it's the entire team taking care of all of you. And just thanks goes out to everybody for participating in this. And I think that we can keep these outcomes going. You can see we've sort of projected ahead over the course of the next year or so. And it looks like our outcomes will continue to be very, very good. Next slide. So what's new and what's different? So some of the stuff you've seen before and some of the stuff we may be talking to you about in clinics. So I just wanted to kind of introduce it here so you maybe hear it here first. The thing that many of you, or probably most of you, are familiar with is donor-derived cell-free DNA. And so for people who aren't familiar with the concept, we know that we can detect the DNA of your donor heart in your bloodstream. And so this helps us determine sort of who's at risk for rejection, because when you're having rejection and it's and cells in your transplanted heart are dying, we can detect that higher level of DNA in your blood. And so we use this to screen for rejection rather than doing biopsies. And the nice thing about this technology compared to even prior technologies like gene expression profiling, that's the AlloMap test, is that we can start using it very early after transplant. So we started using it now about a month after transplant. So most patients get a biopsy at 3 weeks, a biopsy at 2 weeks and a biopsy at 3 weeks, and then we switch over to this non-invasive testing around 1 month. And if you look at our data, and then that's the picture below the donor-derived cell-free DNA, of the course of the past couple of years when we've really been using this compared to prior eras when we really only had AlloMap testing, you can see we've gone from about 9 biopsies a year in the first year to about 3 biopsies even in the first year. So it's a real huge step forward. I think that nobody likes biopsies. We don't like doing them. You don't like having them. So it's nice to be able to kind of monitor you after transplant without having to do a biopsy. And when we look at outcomes, they're just the same. People's ejection fractions, when we look at things like vasculopathy, when we look at rejection, it's the same. So it's very, very safe and it's super convenient. Next slide. 2 other studies that we're doing now that you may have heard about. One is the PCSK9 study. PCSK9 is kind of a mouthful. It's sort of a new drug to treat lipids. And the thought is if we treat early and aggressively with this medicine versus the statin medicines, which we have most of you on, that we might be able to reduce the incidence of vasculopathy. So what's vasculopathy? If you look at the picture there on the left, that's the kind of coronary disease that patients get after transplant. On top, you see the kind of coronary disease that people who haven't had a transplant get, where you think about lipids forming inside of the blood vessels of the heart. With transplant vasculopathy, what you get is actually sort of a thickening of the lining of the blood vessels so that the blood vessel kind of progressively narrows over time. And so what this study is we're looking at this new drug to see if really aggressive lipid reduction will reduce the incidence of vasculopathy. And that's important because that's one of the things that contributes most to death after transplant, particularly beyond sort of year 5 to maybe 10. Just to kind of give you a sense of what things look like, you can see there below is a picture of what the ultrasound that we take inside of your arteries during the testing looks like. So the big black circle is the inside of your artery in your heart, and the sort of green and red is highlighting the thickening that we can see with this technology, and the thickening we hope that will be reduced with this drug. So we've been enrolling pretty steadily. Hopefully we'll have some results soon to share with you for maybe next year. Next slide. And then lastly, the newest kind of kid on the block is the Microbiome Study. So we know that inside of our intestines lives a lot of other little creatures, bacteria and otherwise, and we can detect and kind of determine the relative presence of those bacteria through time. And we see when people get sick, when they get heart failure, and certainly after they get transplanted and immunosuppressed, the kinds and numbers of those bacteria change over from day to day and from month to month. And what we're wanting to look to do to see is if we can detect changes in your microbiome and what those changes mean in terms of how well you'll do or how well your graft will function or your risk for things like rejection or infection. So we may be approaching you. This study includes people 1 year after transplant. So once you reach your 1 year anniversary, we may talk to you in clinic about the Microbiome Study. Next slide. So I think this is the most interesting and important thing, is particularly for the audience that's part of the post-transplant group that are at home and sort of trying to get better information from the program. I know that many of you have been frustrated with our website. It's not that awesome, despite the fact that we're in Silicon Valley. But we've contracted with an independent group that's actually helping us to develop our own website. That's the URL on the top. It's not yet live, probably in about a month or so. And you might say, why does it say heart failure, not heart transplant? Well, it's because we're trying to kind of reach out to sort of everybody that we serve, both the heart failure patients before transplant, as well as the heart transplant patients and the patients with VADs. But why I kind of bring it up here tonight is not only to show you kind of what it looks like. There's a sample page there you can see from the clinic page. But we'll be able to do a lot of things, updating in real time. So we'll be able to put notices on the website and then tell you that we've updated things. I think probably the place where this has become most important is with COVID and the new shots and the new treatments. What are we now recommending? And so we can really change those things as we learn about them in real time, and then direct you to the website to find out that information. I think the other thing that we want to work with you and the PFAC is to determine sort of what are your frequently asked questions? What are things that we can put on the website, or what are resources we can link to on the website that allows you to kind of better take care of yourself or answer questions or just to kind of find more information to learn more about a topic. I think ongoing education is also something that we've heard that you want, and we want to also see how we can use the website to address that need of education, not just before transplant, but for years going on after transplant. And lastly, we know many of you have really fascinating stories. We're going to hear about a couple of them this evening, and we'd like to see if we can share those stories, if you're willing to share those stories with us and with the transplant community. I think patients who are waiting for transplant like to see what happens and what stories people have to tell after transplant. And I think the post-transplant community also likes to kind of catch up and see what's happening with the people that they've either been through transplant with or that they've seen at some of these reunions. So hopefully in about a month, next slide, we'll have this, and we'll let you know that this site is up and active, and then we're going to work with you to hopefully fill that website full of content that your guys will find very useful in the future. So with that, I'm going to introduce you to the polling. So we're going to do some polling this evening that will hopefully give us a little bit more insight into some of your thoughts about certain issues. And again, these are all anonymous. We won't be able to tell who answered what, but this will hopefully give us some information that will help the PFAC serve you a little bit better. So how you do it. So maybe go back 2 slides. No, go back one more. Well, so let me talk about the Zoom chat. So if you want to chat, you can see that there's that chat icon at the bottom, and when that chat window opens, you can either reply to everybody, or if you click on that everyone and that caret next to it, you can see individual people and you can respond to a particular person. So for the next slide, I think this is sort of more about the chat, so you can type your message there and then hit enter, and then it'll go out either to everybody or to whomever you selected. So this is what I wanted to make sure that we did a dry run to make sure it's working. So a poll. So we'll have some polls come up, and you'll see a question with some choices. And then you can go ahead and click on those choices. Why don't you go ahead and click on those now just to make sure you know how to use it. We'll leave it up for about 10 seconds. I can see that we have about 47 people participating in the poll. About 25% of them have answered so far. I'll give you a little bit longer to get familiar with this. We won't leave it quite so long for each question, just so it's not up there too long. But we have about 28 of the 47 of you participated, and we can see that you've been able to sort of find the sample question on your computer and been able to answer it. So again, we'll reach out to you as the evening rolls on with some more questions just to find out a little bit more about the audience's preferences. So with that, I'd like to turn it over to Michael Volstead. Many of you know Michael. He was transplanted here in 2013. He's been really involved with the PFAC for about 6 years and is now chair of the PFAC. I always find it embarrassing to talk to Michael in clinic when I ask him what he's been doing, because he's always doing way more than I am, hiking and biking and skiing. And sort of a little known fact about Michael is he has a dog named Gabby, after Gabby Ora, one of our transplant coordinators, who's now moved on to the inpatient side, so some of you may not know her. But I'll turn it over to Michael to give you a welcome from the PFAC and to give you a little bit more information about this evening.
Thank you. Good evening and welcome to the 3rd annual virtual symposium presented to you by the Stanford Heart Transplant Patient, Family, and Advisory Council. Our council is made up of 10 patients, 3 caregivers, and 2 faculty advisors, nurse practitioner Gabby Oro, and our lead faculty advisor, research nurse manager Helen Lucart. Now, for the last 2 years, COVID has dominated much of our time and energy to the point where it has literally controlled our lives. I felt the same loss of control when my heart went into total failure. Suddenly, I was dependent upon so many people, and this dependency continued on throughout my first year of my heart transplant. Our dedicated doctors, nurses, social workers, and caregivers took care of us like a newborn infant. But as time goes on, the training wheels come off, and suddenly you begin to realize, I need to start to learn to take over for myself. This is called empowerment. And according to the dictionary, empowerment is the journey where you learn to become stronger and more confident in dealing with oneself. Our PFAC thought that empowerment was so important that we dedicated this entire year to it. If you had noticed, our newsletter and this symposium is all about learning to take over. We have to become more proactive in our own medical needs by staying up on our meds, our blood draws, our appointments, and yes, whether we like it or not, to try to continue to live a healthy and active lifestyle. Our donors and our doctors gave us the greatest gift. They gave us the gift of life. And who knows better than us that life is definitely worth living? So if you've not already started to empower yourself, now is the time. Here are a few tips to help you with this journey. Number one, surround yourself with positive people. Laughter is still the best medicine. Practice self-care. Take the time out to do activities that you enjoy and use positive self-talk. In other words, use the word can instead of can't. And finally, live every day with gratitude. I truly believe that the key to happiness is gratitude. Self-empowered people who take control of their lives tend to be happier and more fulfilled. They tend to live a richer and fuller life. And who doesn't want that? So with that, let's put a smile on our face and let's get after it. Now, before I turn this back to Dr. Teuteberg, we now have our first two polling questions. And remember, these are completely anonymous. So here comes question number one. Question number one, how would you rate the semi-annual Stanford Heart Transplant newsletter? Very relevant, relevant, limited relevant, no relevance whatsoever, or I do not receive the newsletter. So far, I kind of like those returns coming in since I'm the chair, so that's good. Got a couple more seconds. Okay, I think you guys are finishing up there. So now let's turn to the second question. The second question is, here it comes. Guess a couple more people are writing. There we go. How many COVID vaccine shots and Evusheld antibody shots have you received combined? 0, 1, 2, 3, 4, or are you an overachiever and received 5 or more? Now for me, as I think about it, I've received 4 vaccines and 1 Evusheld. But now I've noticed it's been over 6 months from my Evusheld, so I'm about ready to sign up again. Give you a couple more seconds. It's like quite a few of you have done at least 4. Okay, thank you very much. As you finish that up, there will be a couple more questions later in the presentation, but now it's time to turn it back to Dr. Teuteberg. Dr. Teuteberg, take it away.
Thanks, Michael, and I really appreciate all the work you've done with the PFAC. And for people who aren't familiar with the PFAC or would like to become involved, please reach out to Michael. There's lots of fantastic resources out there. So before we turn it over to our first speaker for the evening, I would like to introduce Dr. Eldrin Lewis. Many of you got to know Eldrin over the course of the past couple of years. So as you know, Eldrin is our division chief of cardiology, and more importantly, he's a heart failure transplant cardiologist. So Eldrin, I'll turn it over to you.
Thank you very much, Jeff. I really appreciate it. And I actually just want to start off by just saying greetings. It's been an exciting journey for me. Now I've been here for about 2.5 years. And I remember the first time I did this, I didn't know almost anyone. And now from going to transplant clinic and also helping on the inpatient service, I've had an opportunity to meet some of you. And I've just been really excited about everything. So I would start by saying that I wish we could be in person. It's always nice to shake hands and to just celebrate in person. But I think this is an opportunity to allow so many people to get educated, to connect. And we're realizing that this is the new normal. I'd like to thank the whole team, certainly Dr. Teuteberg and thanks to Helen and all the organizers in putting this together. Thanks to the leaders in the PFAC as we kind of continue to think about how we can make things better for our patients during the pre, peri, and post period after heart transplantation. I'm really excited about the additional talks that are coming up. So I just wanted to just give a few thoughts that were on my mind. The first is just a little bit about myself. As Jeff said, I am the Chief of Cardiovascular Medicine. But before I came here 2.5 years ago, for those of you who don't know me, I was at Harvard Medical School, and I've been doing heart transplantation for almost 2 decades. And I've seen all of these stories, all the different permutations. And as people kind of talk about kind of what to expect, the first thing I say is expect to be you. Expect to be you. That we as providers can give you general understandings of what to expect, but for every person, that journey is just a little different. It's not exactly the same, and that's okay. So as I came to Stanford to go from a program where we didn't have the number of transplants to a program here where there's so many people whose lives are changed every year, it makes me even more invigorated to come up with better strategies to better understand how to provide care, how to help patients both in the pre-period all the way to the post-period. And we here at Stanford are committed during the entire journey. All of you are either post-transplant or you're a family member of someone who's experienced the transplantation, and that's really important. But we know that that pre-period can be really daunting. One of the scary things that one hears, even when they're struggling with their heart failure, is you may need a heart transplant. This is how we plan to get you to it. Those are words that can be anxiety provoking. And then the next big moment is when you get the call to come in for the heart transplant, that we found a heart. And there's excitement and then anxiety. And then you get through that period, the peri-transplant period, and there's a lot of stuff to learn, and you're relearning things that you never knew before. And we have a great team that helps everyone. And then you go home and there's another anxiety. And I'm sure some of you have experienced that, said, okay, so I had an entire team behind me, but now I'm home. What can I do? What should I worry about? Should I be nervous about this versus that? And then we have the post-transplant journey, and we're all on that now. And these are all exciting. The reason I bring this up is every step, you're not alone. Every step, you're not alone. There's an old adage that I like to use, and it's an African proverb, it takes a village to raise a child. And I often will say it takes a village to take care of a heart transplant patient. And that village includes the team here at Stanford, but it includes your team, and you're a part of that team. And it's important to take care of that team, because there are a lot of times when there are stressors in life, there are kind of anxieties, once again, that come up. And if you can lean on your team, both here at Stanford and at home, it goes a long way to kind of helping get you through that. The other thing I would just emphasize is we often will talk about primary prevention of heart disease, primordial prevention of heart disease. And you hear these things in the community. Let's control high blood pressure, control diabetes, and prevent diabetes. Not smoke, exercise, eat well, etc. I think there's also the primary prevention of complications post-heart transplant. So just because you have a new heart, you have a new lease on life, you feel great for many of you, and you say, wow, this is awesome, doesn't mean that we forget about all of these different things. So it's still important to watch your salt and watch what you're eating, and to exercise and to keep your heart healthy, but more importantly, to do all of the follow-up. Because while we transplant people to maximize quality of life and quantity of life, we understand that there are some trade-offs and there are some things that we have to be worried about. And when I say worry, I don't want you being anxious about it, but you just have to kind of make sure. I remember giving a talk when I was back in Boston to a bunch of people. I think it was over 100 people, and it just happened to be 100 men. It was some kind of men kind of group that they invited me to talk about health. And I asked by a show of hands, the number of people who actually saw their primary care doctor, did primary prevention, checked, did a colonoscopy, checked their blood pressure, and the hands were not up, not enough. And I said, okay, how many people have gotten their oil changed in their car and have gotten their tires rotated? And almost everyone's hand is up. And I said, wait a minute, so you're telling me that your car is more important than you. It's more important than you. And so there are some kind of preventive maintenance things that we have to do. And it doesn't mean that you can't still enjoy your life, but just kind of do those checkups. And that's very important. The other thing is, don't be afraid to ask questions. Don't be afraid if something comes up. Dr. Google is very active and it's expansive. You can read Dr. Google all day and still not have enough time to read everything that's on there, but it's not vetted. And so you may have anxiety that's created from that, from data that's not accurate. So if there's a question, come to clinic with the question. So you know what, I read on Google that I should be worried about A, B, and C. And then Dr. Teuteberg will be happy to answer that in the meetings. Make sure that it's when he's in clinic. When you come to see me, let's just say I'm doing great. And the last few things I'll say in closing is, the emotional side. It's okay to reach out if you're having a bad day. Anxiety, depression, tired, especially when you have a whole bunch of stuff that's coming up unexpectedly. Reach out if you're having some issues, and know that we're here to navigate. And so think of us as a pilot on a plane that's flying, in perpetuity. So if there's a bumpy road, there's some storm clouds, we have the right pilots, we have the right crew to help navigate you through those things. And one of the things that our team continues to do is to be transparent with you and to let you know what we're concerned about, and then to let you know this is the best strategy forward. So the last point that I would make is COVID. COVID is the elephant in the room, because you hear all of these different things about it, and we acknowledge that a lot of people are concerned about it. And do you have to be safe? Yes. Do you have to be careful? Absolutely, and follow the right precautions. But you should live your life. It's really important that you don't kind of become kind of trapped and say, I'm not going anywhere, but just use precaution when you're actually going out, and enjoy your life, because that's the reason you have the heart transplant. And we'll certainly keep you informed of any late-breaking information that's available. And if you have any questions at all, call your transplant coordinator. The last thing, I keep saying last thing. So the last thing I'll say is, this is what happens when I have no script. I'm just talking freestyle. Your primary care doctor is an important part of the team as well. And so there are a lot of things that we do, but it's important to see your primary care doctor. Just because you have a heart transplant doesn't mean you can forget about your mammograms, or forget about the colonoscopies, or the PSAs, or all of these different things, because it's a heart transplant cures your heart problem, but it doesn't protect you from skin cancer and from all of the things that we have to worry about. So involve them. And we see transplants, we do so many transplants a year, we see it all the time. Your primary care doctor may have only one patient, and that's you. So they're going to get a kick out of seeing how well you're doing. So it's important to maintain that. So I would say enjoy the rest of the symposium. It's really exciting to see familiar faces, and I'm so excited that we continue to be able to offer this life-changing therapy, and we'll continue to push to have you live life better and longer. So have a great evening. Thank you, Jeff.
Thanks so much, Eldrin. Sort of on the topic of preventive medicine, Our next speaker is going to talk a little bit about high blood pressure. It's something that's really common after transplant, either because you have a history of high blood pressure or because the medicines you're on, or both. So it's really important to your long-term health to manage it correctly. So I'd like to introduce Vivek Bhalla, who better to talk about hypertension than the director of our Stanford Hypertension Center. So Vivek is a nephrologist and very much a friend of the program. He's also sort of a personal friend as well, and I think his most important qualification is that he's married to our very own Karen Cush. So with that as way of introduction, I'll turn it over to Vivek to talk a little bit about hypertension after transplant. Vivek, thanks so much for joining us.
And thank you, Dr. Teuteberg. Thank you very much to Helen Lukart for the invitation, and to you as well. It's an honor and a privilege to be here. Can you hear me all okay? Yes? Okay.
Yes.
I just have a few slides to go over a topic that Dr. Teuteberg introduced, which was blood pressure and high blood pressure after transplant. And I'm here to answer questions as well, but I wanted to just go through a couple of points. On this slide, actually, the picture in the background is a picture from a patent application from about 300 years ago for the first device to measure blood pressure. So we've known about blood pressure for about 300 years, but there are still things we don't know, and transplants have only been around for a few decades. And so we don't know everything there is to know about high blood pressure after heart transplant, but there are a few rules to live by that I wanted to go through. One is that there are medicines that you're all now taking after a heart transplant that are good medicines. I in no way want to imply that they're bad for you, but they do protect your new heart, but they can raise your blood pressure. And having high blood pressure, it can hurt your new heart, or it can hurt other organs like your kidneys. And that's one of the things that I spend time talking about. Next slide, please. So what are some of these medicines that can raise your blood pressure? And some of the blood pressure that people have may be due to these medicines alone. It may be due to a history of high blood pressure from before transplant. Some of those medicines include things like prednisone, or things like Prograf, which has different names depending on the formulation, tacrolimus or Envarsus, or Astagraf. Cyclosporin or Gengraf can also raise blood pressure. Next slide. So what can I do to keep my blood pressure at goal? So the most important answer to that question is, what's the goal blood pressure? And different societies have gotten together around the world. That includes heart societies, that includes kidney societies, both in the United States, in Europe, and in Asia. And it's generally thought that a blood pressure that's less than 130/80 millimeters of mercury most of the time is considered a goal blood pressure. That won't uniformly apply to all of you, but it's a pretty good guess for most of you. It's also really important, unlike the picture that I'm showing, to use a blood pressure cuff that's for the upper arm. Many of you may have a blood pressure cuff, or may be reaching for a blood pressure cuff that you used long before your heart transplant. That may be a wrist cuff. I've also seen some apps on either the Android phone or the iPhone that claim to be useful for blood pressure. There's actually a Fitbit device that actually advertises that it measures blood pressure. And scientifically, the best term I can use for all of that stuff is that it's hogwash. The cuffs for the upper arms is the gold standard right now, and it's the one you should use if you're measuring blood pressure at home, and certainly one that I hope your physicians are using in clinic to measure your blood pressure. To keep blood pressure at goal, there's a lot of different things you can do that happen to be important for other things too. A lower salt diet, which many of you heard before your heart transplant and continue to hear about after your heart transplant, that can keep blood pressure down. As was mentioned earlier by Michael, is continuing to exercise. Also, eating a heart-healthy diet, eating smaller portions can help control weight. And weight is critical for blood pressure, especially when you're on medicines like prednisone, which can contribute to weight gain too. It's really important to maintain small portions if you can. Another thing that comes up with blood pressure are other medications that aren't for your heart, but that can help raise blood pressure as well. And one of those are pain medications. Not every pain medication raises blood pressure. But things like Motrin, ibuprofen, Aleve, if they're taken once in a while, it's no problem. But if they're taken every day and lots of times every day, that can also contribute to raising the blood pressure. Next slide. So what do I have to do to protect my kidneys? I mentioned earlier that high blood pressure can hurt the kidneys. So what does one have to do for that? So the rule that I'd like to go by is kind of a Goldilocks rule. In other words, we don't want the blood pressure to be too high. We want it to be less than 130/80 most of the time. But we also don't want the blood pressure to be too low. In other words, to have it be kind of just right, somewhere in between. And what's too low? So I would say that after a heart transplant with your new heart, a blood pressure that is too low would be something like that would make you dizzy. It's different for everybody, but that would make you dizzy. If the top number in your blood pressure were less than about 100 millimeters of mercury, that would probably be too low for many of you. For some of you, less than 110 millimeters of mercury might also be too low. But one of the ways that I think that's most helpful to protect your kidneys when you're talking about blood pressure is to remember what I call sick day rules. And that's something that we want to keep in mind to avoid really low blood pressure. If you have really low blood pressure, that can actually hurt your kidneys in the short term. And so we want to avoid that. And one of the best ways to avoid that is to follow sick day rules. Next slide. So what are sick day rules? So to avoid a really low blood pressure, some of you are feeling great. You've had your heart transplant, but you also know that with a immune system that we've on purpose tamped down to protect your heart, that it's easier to get an infection. And so if you get an infection, or if you're feeling sick or really dehydrated or so nauseous or having diarrhea or having vomiting or belly pain that you can't keep food down, those are times that I would consider to follow a sick day rule. And for that, with doctor's permission, I would hold your blood pressure medications. Because if you're not eating the way you normally eat, not eating the same amount of salt that you would every day, not eating well, your blood pressure is going to be low anyway. If you then take your blood pressure medicines, then your blood pressure can go from a nice number down to super low. And if the blood pressure gets super low, you can get dizzy, and it can also hurt your kidneys. And so this is a sick day rule is just meant for when you're sick, for when you're temporarily sick. When you're feeling well again, restart your blood pressure. So that's just something that's a little bit too much to write on the side of a pill box, but is a warning for most blood pressure medicines. And I wanted to bring it up here because it's particularly important when you're taking medicines like Prograf or you're taking medicines like Gengraf to be cognizant of this, to protect your kidneys in the long term. So those are the comments that I had, and I'm able to answer questions now or later if you'd like. But I just wanted to, again, thank the organizers. It's an honor to be here to meet all of you. Thank you for your time.
Thanks again, Vivek. We really appreciate that. I appreciate the insights into a thing that we all deal with in terms of high blood pressure, but can be a really critical component to having people do well for the long time, particularly with renal function, which is also something we pay very close attention to in the clinic. So with that, I think we have a couple of poll questions before we get on to the next presentation. So the question is, if allowed, would you and your family consider coming to an in-person symposium at Stanford in the future? Seems like there was a resounding affirmatively answered question there, so that's good. All right, so we lit that one up pretty quickly. So that's a pretty resounding yes. That's fantastic, and I hope that we can offer that in the very near future. Poll question 4 is, how often do you miss a dose of your medication? Now, again, these are anonymous. We're just curious. So once a week, once a month, once a quarter, once a year, and never. So it seems like people are pretty good about taking their medicines. I'm not so sure about you never people, but we'll see. because even I can't take my things the way I'm supposed to, and even when I take an antibiotic for 5 days, I can't take it for 5 days. I usually forget by day 3. So you guys are much better than I am. Great, that's fantastic. So moving on to the next part of the symposium is where we focus on caregivers and care providers. I think we all recognize that one of the most important things for good long-term outcomes is having a good source of support at home. And the support can come from family, it can come from friends, it can come from the church, it can come from a lot of different things, a lot of different places. But they can really share in your successes, and they can really help you get through the low points as well. The guy who trained me in the University of Chicago when I first started being interested in heart transplantation always told me that, we don't transplant a patient, we transplant their entire family. And I think a lot of ways that's very true, because a lot of the same stressors and worries and concerns that patients have, their families have, if not even more so. So I think it's worth spending some time to sort of think about and sort of give credit to the caregivers in all of your lives. And so with that, we're going to turn over to a pre-recorded message from Doi Kuntz. She's the wife of Michael Kuntz, so you can see pictured there. And Michael was transplanted in 2020. So we'll go ahead and start her pre-recorded video.
Hello, my name is Doi, and I became my husband Mike's full-time caregiver when he had his transplant 2 years ago, July of 2020. Since then, it has been a rocky ride, but after almost 2.5 years, he's doing well, he's back at work, and we're finally getting on with a semi-normal life. There are a few issues now, but for the last 2 years, I've handled his medicine, his appointments, going back and forth to Stanford. We live in Fresno, so it is a trip, but they are always accommodating to us and work around our schedule when we need to. He has had his ups and downs with medicine and strength, and after a full day of work, he does need to rest a little bit, but he's getting there. He's about 90%. The transplant itself was a little rough because it was during COVID, so he did do a lot of it by himself at the hospital while I stayed at the hotel down the street. After he got out, we did go over and stay at the Stanford apartments for about 3 months, and then we were back at Stanford every week, and then it went to 2 weeks, and then it went to once a month, and now we're actually all on Zoom or phone visits. His last appointment was his last hospital appointment for his clinic was in August, and from now on it will just be phone calls. We won't have to come over there unless we have to. He does get blood work every now and then, but as a caregiver, I do make sure that he eats well, gets enough sleep, exercise. He is into car racing, and he's, like I said, he's back to normal. As for me as a caregiver, it was hard at times, dealing with him and making sure he was okay. I had to find a balance to take care of myself, because if I didn't take care of myself, then there'd be nobody to take care of him. So we did a lot of walking. We did get back to communications better now. He's more thankful that he's still here, more appreciative of what I take care of. And I have my support group here that when I just can't anymore, I call. We have a weekend away where I don't have to worry so much about him anymore. Our kids, our family and friends have all been very supportive this last couple of years. We understand that his medicine's going to be lifelong, but it is tapering off, so it's not as bad as it was the first few months up to a year. The staff at Stanford and all the clinic, hospital, and the doctors and the nurses are always at our reach with a phone call or a video or an email, and they get right back to us on our questions. and answer us as best they can at the time that he's been out for 2.5 years. I'm really not sure what else to say about being a caregiver. It's a privilege that I am here to take care of him and make sure that he's healthy and lives a lot longer around here for us. My philosophy is you just do it. There's no other choice. And like I said, sometimes it is rough, but those are few and far between, and I wouldn't have it any other way. So again, thank you for listening to me. If you have any questions, you can reach out to Helen. She knows how to get a hold of me. And I'm very thankful for the Stanford whole system over there. And again, I'm not sure what else anybody wants to know about being a caregiver, but as for me, that's just something I fell into with no hesitation. And I'm thankful that I was able to do that for him. Thank you.
Great. I'd like to thank Doi for recording that for us. I think that I bet many of you can sort of echo some of your own experiences and her experiences. And I think that a couple of the things she said, I think really hit home in terms of sometimes your support system needs its own support system, and to make sure that you kind of take time for yourself as well, to make sure you don't lose yourself in the mix of all this. So once again, thank you to all the caregivers who are out there and all the caregivers who are participating on the call tonight. We really couldn't do it without you. The program and everybody else couldn't have achieved what they have achieved without you as well. So with that, maybe I'll move on to a couple quick polling questions, see if we can get those up. So the poll question 5 is, how often do you exercise? More than 5 days a week, 3 to 5 days, 1 to 3, or less than 1 day? Again, you guys are making me feel bad about myself because it seems like you're pretty active, which is fantastic. Maybe you can motivate me to get out there and do a little bit more exercise. That's great. So it looks like a lot of people are exercising pretty frequently. Poll 6 is, how many hours a night do you sleep on average? 8, 6 to 8, or less than 6? So it looks like you're getting a goodly amount of sleep. Most of you sleeping at least 6 hours. That's fantastic. All right. Well, that was very helpful. Again, thank you for participating in these polls. So the next speaker is Levester Law. He's going to give a recorded talk as well. The title of his talk is Irrational Confidence. Many of you may know Levester. He's also been very, very involved in the PFAC and very, very involved with peer-to-peer mentoring, and has been sort of one of the core people that has helped the transplant program kind of reach out to the patients and not only sort of feed information back to the patients, but gather information from the patients to feed back to the program to make it better. He's been married to his wife, Joan, for about 35 years. He's retired now and lives with his 3 sons in Mill Valley. He was transplanted in 2012, and we'll turn the floor over to him in a pre-recorded video message.
Thanks, Dr. Teuteberg. I'm truly honored to be here today and pleased to share my journey with everyone. Like most of you, my journey has been a bumpy ride filled with frustration, challenge, stumbles, and successes. So as I prepared for today's talk, I reflected on what has kept me going. Why am I here today speaking with you and not curled up in bed feeling sorry for myself? Those thoughts led me to title my speech Irrational Confidence. Because for me, irrational confidence is an unshakable belief in the power of possibility. Put even simpler, a belief that anything is possible. You see, saying that anything is possible isn't irrational, but us true believers don't curl up in bed feeling sorry for ourselves, at least not every day. Instead, we live our days attempting to push boundaries and believing that despite our circumstances, seemingly unrealistic goals and accomplishments lie firmly within our reach. My transplant journey began with an unexplained decline in physical activity. Within a short period of time, activities I took for granted became more difficult. Walking, work, family, playing with the kids became more challenging. I told myself I was just getting old, but it wasn't natural to be so exhausted that I couldn't even make it into the office. I began working from home. I'd take breaks, sometimes even naps between conference calls and meetings. Finally, I was confronted with the reality. This was more than just getting older. I was sick. It was like one of those nightmares where you find yourself inside a stranger's house, blinded by the darkness, in unfamiliar surroundings, not knowing what obstacles lie ahead, trying to navigate your way out of this darkness back to the safety of your home and the comfort of your family. But I needed the help of skilled medical professionals to navigate this darkness. And after many months of testing, they suspected the true cause of my decline. In the spring of 2012, I was diagnosed with a rare genetic disease called ATTR amyloidosis, a disease that caused my heart to fail and a need for a transplant. So let's fast forward to the early morning of August 22nd, 2012. I received my heart transplant right here at Stanford. The surgery was a success. My focus shifts from survival to recovery. Immediate goals were to breathe deeply, climb out of bed, and walk without falling. Next, my wife and I learned that our 3 sons also have a chance of inheriting this same disease. So I wanted them to be prepared and understand that regardless of the difficulty, anything is possible. I wanted them to see me take control of my recovery, regain control of my life, to become an example of hope, optimism, and determination. An inner voice that lets them know they can and will beat back their own difficulties. During these past 10 years, I've watched and have been inspired by other displays of irrational confidence. Displays from people like firefighters who rush into burning buildings only thinking of the lives they'll save. And the example displayed by Golden State Warriors Klay Thompson. In 2019, Mr. Thompson suffered a devastating knee injury. He endured the setback of surgery, recovery, and rehab. We all know the drill. Sit up, stand up, walk, and move. Then just before his expected return, Mr. Thompson ruptured his Achilles tendon. The result was an added 13-month setback. Now, I will not pretend to know what it was like for Mr. Thompson. Everyone's journey is different. I do understand that in addition to his love of basketball, Mr. Thompson loves the water. And as a sailor, he adopts the motto, smooth waters never made a skilled sailor. Mr. Thompson doesn't let missed basketball shots nor the rough waters of recovery define himself. Instead, he transforms his difficulties into stepping stones of achievement. As a patient and as a player, Mr. Thompson refuses to be beaten back by difficulty. His irrational confidence leads him to a remarkable recovery and return to the game of basketball he loves so much. Also, in the spring of 2017, I was inspired by another example of irrational confidence. I had hip replacement surgery. My rehab included walking around our high school track, first using a walker, then a cane, and finally unassisted. And while walking, I noticed a man standing in the middle of the track, leaning on his forearm crutches. Here's what made this man so remarkable to me. Following the short rest, he'd slowly move one leg, then the next. Each step, every inch of motion was draining, yet he remained laser focused, showing no signs of the pain or frustration he most certainly must have felt. And though I never saw him complete more than several steps, his perseverance was equal to an Olympian, inspired by his power of possibility. I eventually spoke with this stranger. He told me that he'd been in an accident and he was told he'd most likely never walk again. As we spoke, I also learned it was neither distance nor speed of pace that made this man so special. You see, each step was a triumph. Each step was his refusal to be beaten back by difficulty. He told me that despite conventional wisdom, one day he'd walk again. This nameless man and Klay Thompson decided to push the boundaries of expectation and normalcy. I saw the power of possibility in their efforts. Their optimism reminds me that I have a choice. We all do. Never forget, there's glory in our efforts, no matter how large or small. Now, when I look out at our heart transplant family, the patients, caregivers, doctors, nurses, pharmacists, and staff, I see that same brand of irrational confidence, redefining normalcy and reaffirming life after transplant, each day pushing the boundaries of expectation. You know, we all come from different walks of life, yet we singularly share the gift of empowerment, the choice to become better versions of ourselves, redefining possibility and inspiring others to do the same. Following my 10-year transplant anniversary, I now look back on my irrational confidence and I ask myself, what's next? Well, continue taking one step at a time, setting goals, working through roadblocks and barriers, and coming out the other side with a strong sense of accomplishment and an empathy for others who may be suffering. Others just like you and me, who wake up with goals as simple as getting out of bed before noon or getting out of bed at all. Others who, despite their struggles, gather the strength and energy to assume the role of parent, spouse, work colleague, friend. There's enough irrational confidence inside each of us to believe that anything is possible. Whether good times or bad, we must maintain our ability to persist. Now, as for me, my mobility is lessened and I walk using a cane. So my goals have shifted. Walk without a cane. Complete my second book, and against the odds, know that I will become a published author. I will draw upon the optimism and strength of Joan, my wife, and our 3 children, Tom, Daniel, and Paul. I will continue to be inspired by people like Clay Thompson and the nameless man walking at the high school track, and by people like you who choose optimism and accomplishment over idleness. Patients like you and me who are proof that the miracle of heart transplantation continues to thrive. Now, irrational confidence by itself isn't the answer, but it's a great start that opens our minds to the power of possibility over uncertainty. I want to be the person that writes and publishes a book without having done so before, to encourage and empower others to find their irrational confidence and to redefine what's possible for them. I'm here to admit that I'm not perfect. Nobody is. Sometimes I find myself in a fog of self-doubt and disbelief. But if we forgive ourselves for these feelings, we make room to appreciate all those who sacrifice to make our stories possible, whose large and small contributions empower us and enable us to grow in ways previously thought impossible. I'm here today to admit, to confess, and convince each of you we are living proof that impossible is nothing. Thank you.
Thank you, Levester. That was an excellent presentation. In fact, I would like to take this time to thank all of our presenters today, starting with our host, Dr. Teuteberg, the chief, Dr. Lewis, our kidney specialist, Dr. Bhalla, our caregiver, Doi Kuntz, and of course, Levester Law, who you just listened to. As we finish up this symposium, I want to celebrate all of our stars, from the newly transplanted to 35 plus years. Congratulations to all of our courageous fellow transplants and the wonderful caregivers. Welcome to the club, and it is a very special club. We also want to give a thank you. This is coming from the Stanford Heart Transplant Clinic. They are grateful for the opportunity to reconnect with our transplant patients, caregivers, friends, and family. Remember, they are always here for your health and safety. The Heart Transplant Clinic are here for you and to make certain you have the best tools and information for the smoothest possible journey. So that finishes up our symposium, but it's not over yet.